So my name is Jared Steinklein, neuroradiologist and head and neck imager at Lennox Hospital, part of Northwell Health System, and at the Distinguished Lennox Hospital with David Langer, as you can see, who is listening in, I believe, but there he is, and part of the Brain Turns summer webinar series. Okay, next, you can skip to the third slide. All right, so we're going to review some techniques of cranial nerve imaging, of every imaging. Keep it brief because we got to go quickly. Go over some relevant skull-base anatomy and then the cranial nerves. There's 12 of them, so a lot to talk about the anatomy physiology. This is all review in kind of quick fire blitz fashion. And then imaging examples of a couple of neuropathies, things we see from time to time. Okay, next. All right, so CT is superior for bony evaluation. Just kind of remember that. It's quick, you get good spatial resolution and actually exquisite contrast resolution of the bones. But it is ionizing radiation. We're ever more aware of radiation risks of scanning, so we use it judiciously, especially in kids. But we can't really discriminate the nerves on CT, so that's what MRI is really used for. And the techniques have gotten better and better through the years to see all the cranial nerves, which we're going to review. Next. Okay, so it's a lot of nerves, right? It's 12 nerves and it's going to take us half an hour at the minimum. And now, clock is ticking to review all of them. So you have to limit the anatomy that you're scanning to look for, okay? So we'll go through that. Basically from the orbit down to the throat and thoracic inlet for cranial nerve 12. Next. Okay, so basically a bunch of F's. We'll talk about the function of the nerve, the foramen or fissure, or the exit site of the nerve, the findings on the imaging, and then a few pathologic entities, showcase here and there. But again, clock is ticking. Next. All right, so function. Cranial nerve 1 is the olfactory nerve. That is a special sensory nerve. It's smell. Okay, that's it. Cranial nerve 2 is the optic nerve. That's special nerve sensory. That's your vision. That's all it does. 3 is motor to most of your muscles that control your eye movements and does have some autonomic innervation. 4 is a small little motor nerve we'll go through. 5 is very complicated, and we'll get there. As you can see on that list right there, it has a lot of sensory sensation to your face. I don't know if anyone showed you a picture of the homunculus. It's one of my favorite medical words. Homunculus, I believe, homunculus. Now I feel like I'm on spelling bee. So look that up, Google. There's so much sensory innervation to the face. So that's why cranial nerve 5 is the biggest and the broadest and the most complicated one to image. Next. All right, 6, motor nerve, small lateral rectus muscles. 7 is a very valuable nerve. It controls our facial expression, so we can talk, so we can speak, so we can smile. Salivation, taste to your tongue. 8 is hearing, invaluable, and vestibular function, invaluable as well. Next. 9 is a small little sensory nerve, mostly a little bit of muscles. Not much to say. 10 is a very important nerve, the vagus nerve, the longest nerve in the body. So vagus, I'm big into etymology. I love talking about the roots and origins of words. And vagus, like vagabond, that's how they named it, because it wandered really pretty much from the skull base way down to the abdomen, really. 11 is a small motor nerve, accessory nerve. It joins along with other cervical nerves to innervate a couple muscles in the neck. 12, the last one, innervates the tongue, pretty much. One side, one on each side. Next things. All right, so skull base, valuable real estate. Here's a 3D model printed. Obviously, it's not 3D, it's virtual now, but I have one sitting on my shelf. Wait, hold on. One sec. So you can actually see it. This was, and it's kind of cool that it correlates, and I can do this, but anyway, this was 3D printed a few years ago by some people we know. So that's pretty cool. So I can teach, our residents and you guys, but here we have it on screen. Next. All right, number one. All right, so now we're talking about the F, the foramina of the fissures. Where does it come out? So this comes out of the cribriform plate, very thin part of your bone and your skull base. You can see the arrow is pointing. It's right at the center. Very, very thin bone separating the black, which is the air in your sinonasal cavity, and the brain, the olfactory bulbs, the meninges, the CSF, the dura. The paper thin bone is really separating that from your snot, essentially. So it's very valuable bone. Not only that, for that reason, that it's such a delicate area, but it also transmits a sense of smell. Next. 2 is the optic canal. It's its own canal. So the arrow points to the canal, and the arrow is sitting right on top of the clinoid process, which we'll talk about in a second. And it's part of the lesser wing of the sphenoid. Next. Okay, so periorbital fissure, there's a lot going on here. So lateral, so now you see the arrow, instead of being on the, sorry, excuse the dogs, on the left side of the clinoid process, right? It's more further away. It's anterior and lateral. So it's a cleft between the wings, and it has the cranial nerves listed there. All right, next. All right, V2 has its own special crevices, canals. Foramen rotundum is where it exits from the sphenoid bone, from the cavernous sinuses. Next. And has connection, there you can see on the coronal, sorry. Next. Connection here into the face. So that's where things get really, tricky to image, because things are kind of going in, going out. There's a very broad interconnection between the skull base and the face at this junction. So cranial nerve 5 is, again, very complicated, as you can tell, but it's a route of tumor spread. And that's what I wanted to show based on this for sinonasal cancers, to get to the skull base, to get to the point where they're just inoperable. And we have to find, where the disease is, so they can treat it. Next. Okay, V3, so the third division of the trigeminal nerve, has its own hole, and that's foramen ovale. They weren't very creative here. It looks like an oval, and it's pretty much in the base of the greater wing and sphenoid. Okay, next. And spinosum, you can see there's a tiny little hole just behind ovale, and that is where the middle meningeal artery runs, and a couple of sensory nerves. But if you use your imagination, it looks like the imprint of a high heel shoe, like maybe on like Hollywood Boulevard. Oh wait, no, they use their hands. I don't know where they do they use the hands and the shoes? Wherever they do the shoes. Anyway, that's what it looks like in a piece of concrete, as if it were bones. All right, next. All right, 7 and 8 get their own space, the internal auditory canal, or acoustic meatus, if you're old school. So as you can see, it's an oblique longitudinal canal within that extremely dense bone. In fact, it's the densest bone in your body, called the petrous apex. And that's where cranial nerve 7 and 8 go. Next. All right, 9, 10, 11 all kind of share the space of the jugular foramen, which is illustrated here. You can see we can divide that. You can click next, I believe. There's an animation. Perfect. You can divide that into the pars nervosa, which is the red side, or the left side of the picture. Kind of looks like Mickey Mouse's ears. So that transmits the ninth nerve and some sinus, venous sinus. Whereas the larger portion, the yellow chamber, has the jugular bulb and 9 and cranial nerves 10 and 11. Next. 12 gets its own canal way down and more medially, kind of in the occipital condyle. You can see in the arrows here. And we're often taught, it looks like an eagle's beak, but I'm from New York. So next, to me, it's a little, there you go. So it's not as beautiful as an eagle, but it looks like this baby pigeon from Central Park from New York. So that's my stupid little joke. All right, so now let's go through some more imaging and pathology. And we do it well with time.
Yeah, you're doing great. Question quickly.
Yes.
Do you know if you'd be able to share these slides? A couple people asked, like if I could like share them with the group, or.
Yeah, no, I can make it shareable afterwards. Yeah.
Okay, I can post it in our Facebook group. But anyway, sorry.
No, don't do that. I'll send you a separate version.
Okay,
because some images I will have to like de-identify or stuff. I wasn't 100%, so I have to make sure it's safe to go. But yeah,
okay, perfect.
I'd be
Okay,
happy to share. Mhm.
you. All right, continuing.
Okay, so back to reviewing the 12. All right, so here, number one, the olfactory nerves. I'm showing you the olfactory really, groove within the anterior skull base there. You can see, if you really squint, a bunch of tiny little perforations. So cribriform plates, there they are. Next. So these are afferent systems, so the sense of smell. And that suffix, again, back to the etymology, being osmia. So I'm sure everyone has heard of anosmia these days, and especially in its association with COVID. But most often it's trauma, it's injury to that frontal lobe region. You can see on the graphic there, the bulb is really at the base of the skull where the frontal lobe and associated nerves are prone to injury. Tumor, it's a really common spot for meningioma to happen, so that's possible, or a sinonasal tumor such as esthesioneuroblastoma. That's another word of the day for all of you, esthesioneuroblastoma, which is which we see quite a bit for a pretty rare tumor, but it's classic for this spot. And then again, COVID infection, we think it's real. It has to be, and this nerve, as you can tell, it's kind of really close, contiguous with the brain in broad aspect, and it's actually not, lined by Schwann cells. It's oligodendrocytes of the bulb. So it's not really a peripheral nerve. So it makes sense. Next. Okay, so here's just some examples of the bulb on MRI. So the left, I'm sorry, the top image is showing a normal cal of the optic bulb, and going down, you can see there are gradual degrees of olfactory hypoplasia, the bottom being most severe, and that's again associated with Kalman syndrome, which I had on the other slide. Next. And then this is an article my colleagues published actually last year, after collecting and reviewing multiple images on COVID patients, and we were able to, or they were able to, and us to some degree, we were also able to resolve the olfactory bulbs on these 3D images you can see here, and they did compare to normal, and they did see some difference. They didn't have a lot of statistical power, but anyway, so there's still a lot to be known about COVID, as I'm sure all of you know. But it really is true from a medical standpoint, an imaging standpoint for sure. Next. Okay, so here is that big ugly tumor that I was showing, the esthesioneuroblastoma. So it's a classic location. It has these cysts, which are the orange arrows above. But it actually has a better prognosis as other cancers, which are listed down there. It's pretty, responsive to chemo, as opposed to others. Next. Okay, number two, so the optic nerve. So again, the arrow is pointing medial or towards the midline, right, of the clinoid process, that bone that juts out toward the middle. Next. So it's a nerve site, direct extension of the brain. So just like number one, it's not lined by Schwann cells. You don't get schwannomas of your optic nerve or olfactory bulb. So those two, the first two, are unique in that way. And again, it's enclosed by meninges as it goes through into the orbit with fluid. So the CSF around your brain is really in communication with the fluid around your optic nerves. Next. Okay, so here's an arrow depicting the span of the nerve. Most of it is intraorbital, as you see. There's the yellow arrow points to. The orange is the intracanalicular part. But the canal, which is not easy to see on the MR, but it's where the nerve sits at the orange arrow, just has the nerve and the artery, the ophthalmic artery. It tends to be a site often involved by meningiomas or aneurysms, sinus disease, things that we think of benign, but it's just very fragile anatomy for radiologists to be aware of, and for surgeons for sure to be operating around. But the nerve of sight, one would argue might be the most important one. Next. So here is a graphic depicting the optic apparatus. So yellow, again, those are the optic nerves, but now we're intracranially. Green is the chiasm where they connect, and blue points to optic tracts posteriorly as they decussate. They crisscross, and then they travel up, to the tracts and radiation back to the occipital lobes where we process vision. Next. Okay, so here's some examples. So on the left of the green example, this is optic neuritis. So the arrows, the red ones, especially pointing to the enhancement of the long segment nerve. And we see that in some patients with MS. The middle image is, or middle case is a meningioma. So here the enhancement looks kind of more plaque-like, more nodular. You can see it's more rounded, but it has also some linear enhancement as well. These are all MRIs, by the way. Someone just asked, it just popped in, but all right. So again, it's a direct extension of the cranial, of the central nervous system. So it has dura and CSF. So you can get meningiomas, of course. The most common intracranial mass there is can actually arise in the orbit. So benign disease, bad location. Here's a perfect example. So here's an optic glioma. So here you can actually see on this fluid series, there's fluid around the nerve. So it's not coming from the sheath, it's coming from the nerve. And that's an optic glioma. And those are common in neurofibromatosis type 1. Next. Okay, ocular motor nerve. So now we're lateral to the clinoid. That's the superior orbital fissure. Next. Okay, so here you can see going basically from the back to front, the nerve exits. The green arrow is pointing to the interpeduncular cistern, and those tiny little feathery nerves you might see make a V shape in front of it. That's where it comes out. Next. So there it is in the yellow arrow. That's the nerve next to arteries. You can see I'm also pointing it down in the cavernous sinus on the images below. But it's a nerve that kind of travels a long way through a very crowded area with lots of vessels and brain. So it's prone to herniation, compression, tethering. So that's why this is the main nerve that innervates the muscles of your orbit, but also your constrictors, your pupillary constrictor muscle. So when this gets compressed, your pupils get fixed and dilated. So that's why when there's brain herniation, these nerves fail to function. And that's the first evidence of herniation, really. Next. Okay, 4, same hole, next. And it's very small. It's actually unique because it's the smallest one. It's very difficult, almost never seen on MRI. Only seen when it's pathologic. And it's the only one to come out the dorsal or the back side, which I'm pointing to, coming from the nucleus, and then the blue arrow shows it coming back and over to the other side, and red is where the nerve actually crosses. So it's contralateral. So if you have a fourth nerve palsy, you have to look to the other side of the brainstem. Next. Okay, so here's an example of a little schwannoma, which is, again, the most common tumor, the little green arrow. And then on the orbit image down on the right, you can see the blue arrow pointing to the superior oblique muscle, which is atrophic. So little tiny nerve has a little tiny tumor, and the little tiny muscle is atrophic. That's what all these pictures show. Next. All right, so very complicated. We're gonna have to go very quickly here. So top to bottom, superior orbital fissure, inferior orbital fissure, foramen ovale. Again, 1, 2, 3. Next. Okay, very complicated, as you can see on this graphic. The nerve comes out of the brainstem. The Gasserian ganglion, which the red arrows point to, or reddish orange, is the split point, and that's right where the nerve is about to exit the intradural portion of the skull and extradural or skull base portion, which we image. Next. So here's a schwannoma, which is again very, very common. So the green arrows point to the rounded mass, asymmetric certainly, and it's avidly enhancing on the bottom image. And the left side is normal. That's Meckel's cave and little nerve fibers without enhancement. Next. All right, so here's more. This is V1 on top, showing you a mass in the superior orbit. And then on the bottom image, you have a mass multilobular, really infraorbital. We're more at the level of the nasal cavity if you can't see, if you can't tell, correlate. Sorry, I don't have the pointer. But basically, that's a neurofibroma. So that was a patient with NF1. All right, next. All right, the third division of the fifth nerve, sorry. It's the most complex. It has motor, it has sensory, and then it tracks on taste from the lingual nerve, from the corticotome, from the facial nerve. But it's the only branch of the trigeminal nerve that skips the cavernous sinus. So it goes south directly laterally into foramen ovale, which you can see widened on the left image and with an enhancing tumor on the middle image. And the right image shows that the muscles of mastication are atrophic. So you can see there's less bulk of muscle of soft tissue, there's more fat density. Clearly, there's less muscle bulk on that image from long-standing nerve disease. Next. 6, all right, so back to the superior orbital fissure, next. So this is the most common nerve to actually be implicated with any sort of unilateral diplopia. Again, from nucleus to end organ, you can see the red arrow points to the facial colliculus region of the brainstem, of the pons specifically. And the nerve fibers course anteriorly and exit out. And on the left image, you can see the arrows, sorry, they got shifted a little bit, but that little black filling defect, look at the left purple arrow. That's the sixth nerve in a background of CSF. So it's the only nerve to actually course superiorly, and that's why it can be injured. It can be tented from CSF pressure disturbance, but it's also next, I think the next slide has it. Yes, it's the only one that's actually in the cavernous sinus, the middle image shows. The other ones are kind of plaqued along the dura or the lining, the fibrous lining of the sinus, whereas 6 is more susceptible to injury. So that's why we often see it if there's cavernous sinus. Pathology, like the right-sided case, shows the red arrow pointing to a fistula or cavernous CC fistula, which is a cause for diplopia. For a whole other orbital symptoms as well. Next. All right, 7. So you're gonna have to imagine, but the internal auditory canals are coming out, basically almost perpendicular to the bird's eye view here, but those are on both sides tucked away, going again, that petrous apex, that triangle portion of the really dense bone part of the skull base posteriorly. All right, next. All right, so facial nerve has really vital functions. Articulation, blinking, smiling is a really vital nerve, and it's a very complicated nerve. But again, let's start from the back and go forward. So we have the motor nucleus again at the facial colliculus. So 6 and 7 are kind of buddy nuclei back to back. So most of it is motor going to the face, but it does have other functions, as you can see here. And here's an example of an acute infarct. So that's a diffusion weighted scan on the bottom, which is really quick. It takes about 3-4 minutes for us to be able to diagnose a stroke, within 30 minutes of the patient having symptoms. So that's the most sensitive scan we got. And here you can see a tiny little infarct causes, a total left facial palsy. So a big whopping facial droop from such a small stroke in an unfortunate spot, basically. Next. Okay, so here are the arrows. The yellow arrows point to the facial nerve, okay, compared to the bulkier 8th nerve, which we'll talk about in a second, which is in red. And if you look at the bottom left image, you can see the yellow arrow pointing to the facial nerve is tucked away in the anterior and superior view. We're kind of looking at it from the side. but it makes a figure of four appearance of the nerves there. So the mnemonic is 7 up, coke down. So 7 is the facial nerve in yellow, and right below it is the bigger or 8th nerve, which we'll get to in a second. Next. No, we'll skip this. Next, there's a whole lot to know about the facial nerve. 8, again, same hole. So now we're talking next. Yeah, thanks. So we're talking again, same pretty much image, but the bigger bulkier nerve that goes to the IAC. And schwannoma is, of course, the most common diagnosis here in the CP angle-cistern region. Yes, it's the most common mass. And actually 90% plus of them actually come from the vestibular nerve, not the cochlear nerve. So calling it an acoustic neuroma is actually wrong. They're vestibular schwannomas, but they compress the cochlear nerve, causing hearing loss. So just to be a purist, we're calling them vestibular schwannomas. Next. So here we go. Here's a great example. So there's 7 up, coke down. So coke, now the 8th nerve. And here's just some MIPS and volume renderings of the labyrinth. You can get really, really beautiful imaging with MRI to look for labyrinthine obstruction, otoliths or filling defects or things that aren't fluid that you can get sensitivity with imaging on. And then the right side shows the 8th nerve splits into 2 additional vestibular nerves. Next. 9, so it goes down toward the jugular frame, and again, difficult to kind of appreciate. Next. Okay, so here we can vaguely see it coming out of the medulla, but really the more posterior lateral. You can see it has some taste and sensory parasympathetic. So it does have a few, important features here and there. It's not a very, popular nerve because we don't really see disease isolated to the nerve. But, it's very close to 10 and 11, and then they all share the jugular foramen. Next. Next. So 10 is a bigger nerve, obviously the longest nerve and the most vital nerve, I think, probably because it has so much supply to the head, to the neck, to the heart, and to your abdominal viscera. And it supplies motor innervation to your pharynx and your larynx. Your laryngeal nerves are from this cranial nerve. And also provides a lot of good, really important sensory innervation to your throat. So, the gag reflex, or like the Dunkin' Donut powder, like the powdered donut reflex. When you eat a powdered donut and you accidentally inhale and you inhale the fine powdered sugar, you cough. That's because the fine vagal nerves are ticked off, that you've basically violated that part of the airway. So it's actually genius the way it's set up. It's protecting your airway. Next. Here's just some examples. So again, schwannoma. Next. All right, same hole. Next. So again, not much to talk about 11. It's very small, inconspicuous on most in-section MRs that I've seen. But again, with jugular foramen pathology, it's often, seen with the 9th and 10th nerve also being abnormal as well. Next. Okay, so here, schwannoma, a big one at the jugular foramen. This one's already been operated on. It's, there's some residual that needs some radiation therapy, but showing the chronicity of it on the right image, you can see that there's fatty atrophy, there's much thinning, hyperintense T1 signal in the trapezius and sternocleidomastoid muscles, which are innervated by 11. Next. 12, so most inferior now, and more centrally towards the skull base, you have your own foramen at the occipital condyles called the hypoglossal canal. Next. Okay, so here you can vaguely see it. All right, the nucleus, again, yellow. Most nuclei are in the back of the brainstem for the cranial nerves, by the way. And here you can see the fibers traversing again in the yellow, of course, and then the purple arrow pointing to a little strand-like nerve, but it comes out again more in the front. You can see 9 and 10 are still in the picture. They're more lateral and off to the sides. You can see both sides, but there you can see a tiny little 12th nerve with the purple arrow. So that one nerve controls almost all of them, I think, except one, muscles of your tongue. And not only your tongue, you can move around, but the tongue that's intrinsic to swallowing, which I just did, and all that. Okay. So a lesion of the nerve causes the tongue to deviate to the ipsilateral side. Remember that. So in setting of a stroke or whatever, or hypoglossal palsy, the side that actually works is going to push it towards the side that doesn't work. Next. Okay, and here's an example, another schwannoma, surprise, surprise. CT nicely shows the scalloping, kind of widening of all the bone there, really focused more at, deep at the medial skull base. And you can compare, look at the shape. It has a pretty classic dumbbell look to it, or dog bone, or something. It has very rounded lobular, but it kind of squeezes through foramina and mushrooms out in each direction. That's typical of schwannoma. So that's beautifully depicted in that bottom left image. And then here in the middle image, again, the T1 image showing the fat signal as the muscle is atrophic, it gets replaced by fat. So the left image, which the left side of the person, is the right side of the picture for radiology. So the purple arrow shows the atrophic fatty replaced tongue, and you can actually see the tongue shifted, the midline shifted over to the left, to the patient's affected side. Next. All right, we made it. Okay, so it's complex anatomy to know. Nucleus to end organ should be your approach, all right, when you have a cranial neuropathy. We're dealing with the brain, we're dealing with the nerve, or we're dealing with some systemic thing. Is there multiple nerves involved? And again, it's very complex neurophysiology. You cannot teach it in half an hour, but there's tons to know, tons to learn. And I find it fascinating, especially as imaging techniques have gotten better and better. As I've even trained in my young career, I've seen such improvement and better visualization of the nerves and pathology of the nerves. Most common tumor, schwannoma of the cranial nerves. So that's the third word of the day. So there are 3 words: homunculus, schwannoma, and esthesioneuroblastoma. Those are my 3 cranial nerve words of the day. So they're all peripheral nerves. So schwannoma is a peripheral nerve tumor, except for cranial nerve 1 and 2, which were, so schwannoma and esthesioneuroblastoma would not be from the same origin, right? So one is peripheral nerve, and esthesioneuroblastoma is neuroendocrine, not related. But as that kind of alludes to, never stop thinking outside the box. So when it looks like a duck, talks like a duck, it's probably schwannoma, but think outside the box when things don't fit the picture. That's the more